nothing but it is focal or global neurological deficit, right? So let us have a look at these images, and the purpose of this lecture will be that by the end of this lecture we are going to understand these images, right? So guys, this patient presented to us with left-sided hemiparesis. So few images are shown to us. The first image that is shown here, this is a diffusion weighted imaging, right? And every diffusion weighted imaging, it is accompanied by a ADC map. ADC map. The third image here is your flare image, and the last image is the angiography image, right? So we are going to understand these images by the end of these lectures. So first of all, we need to know what is the investigation that we need to go for the patient with history of any stroke, right? So we have been given two images, one is NCCT and the other is MRI, right? So पहले तो हमें पता होना चाहिए कौन सी NCCT है, कौन सी MRI है, right? So the simple way to identify a CT image is to look at the bones, right? So this is a very basic thing that every one of us know, that bones appear white on the NCCT head images, and if we look at the MRI images, you will see that the bones, they are appearing dark. Bones are appearing dark on the MRI images, right? Now one more thing that we need to know is that, if we have to acquire a CT scan of the patient, it will just take us 2 minutes, right? But if we have to acquire an MRI of a patient, it is going to take us approximately 30 minutes, right? So we should know what are the important indications of doing a NCCT, of doing an MRI, right? So if there is any emergency condition, right, like your stroke, like any history of trauma, so we have to treat that patient within the limited period of time. So NCCT is always the investigation of choice in all the emergency conditions like trauma. If there is any foreign body within the eye, again then we are going to go for trauma. So today we are going to just talk about the neurological conditions. And if I talk about MRI, so MRI, all the cases of emergency, NCCT will be the investigation of choice. But there is one case, okay, that is your stroke. For stroke, MRI will be the investigation of choice, and I will tell you in few minutes why MRI is the investigation of choice. And within the trauma also, the exception is diffuse axonal injury. In patients with diffuse axonal injury, okay, after NCCT head, we will always go for MRI. So we will go for MRI in patients with stroke, right? If there is any demyelinating disorder like your multiple sclerosis, neuromyelitis optica, then ADEM, we are going to go for MRI. Then if there is any brain tumor, again your MRI will be the investigation of choice, right? So now coming to the stroke. So guys, stroke can be ischemic as well as they can be hemorrhagic, right? They can be hemorrhagic. And within the ischemic part, the stroke can be of two types. It can be an arterial stroke and it can be a venous stroke, okay, venous infarct. It can be due to occlusion of the vessels of the circle of Willis, or it can be due to the thrombus within the sinuses of the brain, right? So now what is the significance of doing NCCT head in patients with history of stroke? Okay, what is the importance of doing NCCT head? So guys, NCCT head is done to rule out any hemorrhage, because we all know that if there is any patient of infarct, we go for thrombolytic drugs like alteplase. So before going for these thrombolytic drugs, we have to rule out that there is no hemorrhage present within the brain. So for that condition, we are going to go for NCCT head. So NCCT head, the important indication for doing NCCT head in patients of stroke is to rule out any hemorrhage, any intraparenchymal hemorrhage, right? So The stroke can be, hyperacute, it can be acute, subacute, and chronic. And we need to know the imaging features of all these uh, strokes, right? So hyperacute stroke is the stroke that is presenting, okay, to us in less than 1 day. Acute is between 1 to 7 days, and subacute is 8 to 21 days, and chronic is more than 21 days, right? So the most important features that you need to remember is for hyperacute ischemic stroke. The first question that is going to be asked from this topic is that what is the investigation of choice for hyperacute ischemic stroke? So guys, if you are going to do an NCCT head in patients with hyperacute ischemic stroke, most of the times the NCCT head will be normal. And if I talk about MRI, okay, in the MRI also, the T1 weighted images, the T2 weighted images, and the FLAIR images, they may have a normal signal, right? So the best sequence to pick up the imaging features of stroke, hyperacute ischemic stroke, is your diffusion weighted imaging. So guys, this is the same patient that is presenting with left-sided hemiparesis. And what do you see? On the diffusion weighted images, the features will appear as early as 30 minutes, okay? And on the diffusion weighted images, you will see that there will be areas of hyperintensity within the cerebral cortex, right? And these areas of hyperintensity, if you look at these areas on the corresponding ADC map, the same area on the ADC map, it is appearing dark. The same area on the ADC map is appearing dark. So this is what we call as diffusion restriction, that is shown by an area of infarct. So guys, why does diffusion restriction happen? Okay, so that is because of the cytotoxic edema that happens after stroke. Cytotoxic edema, when there is edema within the cell, within the neurons, okay, the contents of the neurons, they are not able to freely move when there is edema of the neurons, and that restricted movement presents as hyperintensities on the diffusion weighted images. Now I told you that on the NCCT head, mostly the images will be normal, okay, but in few cases guys, you are going to see subtle signs on the NCCT head, and let us have a look at those subtle signs. So guys, why does stroke happens? It happens because of the occlusion of vessels by any thrombus, occlusions of vessels by any thrombus, right? Now this thrombus appears hyperdense on CT images, So if there is a stroke that is involving the MCA, so we will see that there will be hyperdensity in the region of MCA. So this is where your MCA travels, the M1 segment of middle cerebral artery in the Sylvian fissure, and this is going to appear bright, and we give this name as dense MCA sign. When the M1 segment of the middle cerebral artery appears bright because of the thrombus within it, we call it as dense MCA sign. And when there is occlusion of the M2 segment, okay, so middle cerebral artery will travel in the Sylvian fissure, then it will divide into two divisions, okay, so these will be the branches of the M2 segment, okay. So M2 segment is going to travel in the Sylvian fissure, right, along the insular cortex, and when there is a thrombus within the M2 segment of the middle cerebral artery, we are going to call it as Sylvian dot sign. We are going to call it as Sylvian dot sign. And when there is a stroke that is involving the posterior circulation, and your posterior circulation, guys, we all know it is supplied by your basilar artery, and if there is a hyperdensity in the basilar artery, guys, what we will see? We will see a stroke that is involving the posterior circulation. And what is the name of the sign? The name of the sign is dense basilar artery sign. So one thing that you need to remember is that the thrombus, it is going to appear hyperdense. So when it occludes your M1 segment, we will call it as dense MCA sign. When it occludes your M2 segment, we will call it as Sylvian dot sign, and when it occludes your basilar artery, it is known as dense basilar artery sign, right? So these are the important imaging features of hyperacute ischemic stroke. Another very important sign. So guys, first of all, these are two regions. Let me label them as A. This is the right cerebral cortex, and this is the left cerebral cortex. So if you look at this image very carefully, you will see that there is a hypodensity in the region of left cerebral cortex, whereas the right cerebral cortex is normal. And if you look, the cortex just below the Sylvian fissure, this is the Sylvian fissure, and the cortex just below the Sylvian fissure, this is known as insular cortex. And if you look at the appearance of this insular cortex, guys, this insular cortex, it is having a wavy appearance, right, like the type of ribbon. Now when there is a hypodensity that is involving the insular cortex, okay, this wavy appearance of the insular cortex is lost, and this is known as loss of insular ribbon sign. Another very important sign that you can see in patients with hyperacute ischemic stroke, right? Now the fifth sign that we are going to talk about. So again, have a look at this image. So these are your NCCT head images, right? And on these NCCT head images, let us have a look at the basal ganglia. So this is your basal ganglia, right? So what is this? This is your caudate nucleus, which is appearing bright, right? And this is your putamen. Now if you look at the left side, on the left side, guys, you are not able to appreciate the basal ganglia. And when you are not able to appreciate the basal ganglia, here comes another very important sign that is known as obscuration of lentiform nucleus. So when lentiform nucleus is not visible on NCCT head images, again you are going to think of hyperacute ischemic stroke. So we have studied 5 signs. One is dense MCA sign, dense basilar artery sign, Sylvian dot sign, loss of insular ribbon sign, and obscuration of the lentiform nucleus, right? So the most important thing, the earliest imaging modality that is going to pick up the imaging features of stroke, that will be the MRI. And within the MRI, the most important sequence is your diffusion weighted imaging, right? So guys, what happens? So once you see, okay, so let us make a flow chart. So we have a patient who has a history of stroke. What history he will give? He can give history of any weakness of the limb. He can give any history of difficulty in speaking, difficulty in talking, or difficulty in understanding, right? You go for NCCT head for this patient, okay? If there is hemorrhage, okay, mostly you will go for conservative management, and conservative management will be in the form of to reduce the intracranial pressure, and intracranial pressure is reduced by giving IV mannitol. Okay, so this was your hemorrhagic stroke. Now if we have ischemic stroke, right, we will do an MRI. Right? And if the patient comes to us within a window period of less than 4.5 hours, within the window period of less than 4.5 hours, and we do an MRI for this patient, and on the diffusion weighted images, there is hyperintensity, right? So we look at two images. One is diffusion weighted images, and another image that we look at is your flare image, right? So let me compare. So if I draw a table, okay, one is a patient with hyperacute stroke that is presenting to us in less than 4.5 hours, and an acute stroke that is presenting to us in more than 6 hours, right? So let me first compare the imaging features on diffusion weighted images, right? So on diffusion weighted images, the hyperacute ischemic stroke will appear bright, very simple, and your acute stroke, it will also appear bright. Then the question is, if we do not have a reliable history, how are we going to differentiate between hyperacute and acute ischemic stroke? Okay, so this we will differentiate with the help of flare images, right? So on the flare images, the hyperacute ischemic stroke, it will appear dark. Okay, it will appear like a normal brain parenchyma, not dark. And on the in patient with acute stroke, on the flare images, the acute stroke will appear bright. On the flare images, right? So whenever the person from the neurology department comes to us and he says that this patient has so and so history of stroke, okay, he asks me that diffusion, there is hyperintensity. So tell me, sir, whether is there any hyperintensity on the flare images? Okay, so tell me whether the patient is flare negative or flare positive, right? So it will, if it is a patient of hyperacute ischemic stroke, the patient will have no hyperintensity on the flare images, which is again going to prove that it is a hyperacute ischemic stroke. Now, when the patient is diagnosed with acute ischemic stroke that is less than 4.5 hours, so the patient, on the MRI table itself, the patient is given an intravenous dose of L-teplase, right? And what is the dose of L-teplase, guys? So it is given 0.9 milligram per kg, right? For example, the weight of the patient is 60 kgs. So the total dose of L-teplase that will be given to the patient will be 56 milligrams, right, approximately. And let me tell you that 10% of this dose is given stat. Okay, 10% of this dose is given to the patient on table itself, on the MRI table itself, and the rest 90% dose is given as an infusion. So this is a very important thing that you guys should remember, right? Now moving on to the acute stroke. Now I told you that hyperacute ischemic stroke, the imaging features may be normal, but the acute ischemic stroke, that is between 1 to 7 days, what you will see that there will be an area of hypodensity. And the most important feature of this hypodensity is that it is involving both your gray matter as well as your white matter. This is the most important feature. it will be wedge shaped, and this hypodensity can also cause mass effect. What do we understand by mass effect? Because there is so much edema within this ischemic tissue, within this infarct, that it is going to swell up, and it is going to compress the adjacent structures. So for example, if we have an infarct involving the left cerebral hemisphere, and there is a ventricle adjacent to it, it is going to cause compression of the ventricle. So these are the important features of acute ischemic stroke. And if I talk about MRI, so on the MRI, this acute ischemic stroke, it is going to show diffusion restriction. It is going to appear bright on T2 weighted images, flare images, and dark on T1 weighted images. So these will be the important features of acute ischemic stroke. Now let us move on to the subacute ischemic stroke. Now a very important phenomenon that is shown by subacute ischemic stroke is that there can be normalization of the hypodensity. So for example, this region was appearing hypodense in a patient with acute ischemic stroke, but if we do imaging in patients with subacute ischemic stroke, this area can appear normal, right? Why it is appearing normal? Because of the hemorrhages which are taking place within the region of infarct, and this area appears like a normal brain parenchymal tissue, right? So these are the features of subacute ischemic stroke, and this phenomenon is known as CT fogging phenomenon. Basically, the findings of CT, they are obscured. And guys, if I talk about MRI, okay, on MRI, this subacute ischemic stroke, it will appear hypointense or dark on T1 weighted images. On T2 weighted images, it is going to appear hyperintense. On the flare images, it is again going to appear hyperintense. Now you are going to ask me, sir, these were the same imaging features of acute stroke as well, right? But I will tell you what happens on diffusion weighted images and ADC, right? So on diffusion weighted images, again it is going to appear hyper. An acute and a hyperacute stroke, it was appearing dark on the ADC map. But it will have in the patients with subacute ischemic stroke, it will have a normal appearance, okay, normal signal intensity. It will not appear dark on the ADC maps, right? This is what we need to know. And also what we can see that there can be gyral hyperintensities. Can be seen, and these gyral hyperintensities, this is due to the phenomenon that is known as cortical laminar necrosis. Because of the necrosis that is taking place within the cortex, that this is known as cortical laminar necrosis, and this appears hyper intense on T1 weighted images. Right? Now this CT images, this is showing you the CT fogging phenomenon. Okay, so the first image, this is the patient with history of acute ischemic stroke, right? So there is a wedge shaped hypodensity can be seen here, but when we do a scan of the same patient 15 days later, we see that there is normalization of this hypodensity, and this phenomenon is known as CT fogging phenomenon seen in subacute ischemic stroke. Now let us talk about Now let us talk about chronic infarct. Chronic infarct. Okay, so chronic infarct, when there is a dead brain tissue that is lying, okay, the neutrophils, the macrophages, they are going to eat that dead brain tissue, and with time what will happen, that dead brain tissue, it is going to liquefy, and when that brain tissue liquefies, it is going to appear like your CSF. It is going to appear like your CSF, right? And what you will see, that there will be an area of hypodensity, and this area of hypodensity, this will have a similar attenuation as that of CSF, and CSF we will see in the ventricles. So if we are seeing a wedge-shaped hypodensity that is having a similar attenuation as that of brain parenchyma, then we are going to think of chronic infarct. And if I have to tell you about the imaging features on MRI, so just remember that a chronic infarct will not show diffusion restriction. It means that it is going to appear dark on diffusion weighted images, right? It is going to appear hypointense on T1, hyperintense on T2 weighted images, hyperintense on T2 weighted images, and on the FLAIR images also there will be partial suppression. Partial suppression means that on the FLAIR images the chronic infarct can appear dark, right? So we have discussed all the important imaging features of acute, hyperacute, subacute and chronic infarcts. So there is another category of infarcts, that is lacunar infarcts. So we should know what is a lacunar infarct. It is an infarct that is less than 2 centimeter in size. So basically it is due to involvement of the thalamostriate and lenticulostriate branches of the circle of Willis. So these are the small branches that are going to supply your basal ganglia, and these strokes can result in pure motor stroke. Okay, there will be just motor involvement. And what are the most common sites? It can involve your basal ganglia, like the one that is shown in the image. So in this image we can see that there is a hypodensity that is involving the left thalamus. Hypodensity that is involving the left thalamus, and it is less than 2 centimeter in size. So this is a case of lacunar infarct, right? So these lacunar infarct, okay, these can be seen on the diffusion weighted images as well. So if it is a hyperacute lacunar infarct, what we are going to see? We will see that there will be a focus of diffusion restriction like the one we are seeing here. So there is a focus of diffusion restriction that can be seen, and the same focus, if you look at this image very carefully, the same focus, it is appearing dark. It means that it is showing diffusion restriction. Right? Now let us talk about few hemorrhagic strokes. So this patient, we can see that there is a hyperdensity that is seen in the region of basal ganglia, right? So guys, what is the most common cause of basal ganglia bleed, BG bleed? So the most common cause is hypertension. And what happens in hypertension, guys? Because vessels within the pressure within the vessel is so high that the thin vessels that are going to supply the lenticulostriate, thalamostriate vessels that are supplying your basal ganglia, they cannot tolerate that much pressure, and because of this they rupture. And when these vessels rupture, there is a bleed within the basal ganglia, and the most common cause is hypertension, right? So this is another patient. So in this patient, we see that there are hyperdensities. There are hyperdensities that are seen along the sulcal spaces. Hyperdensities are seen along the sulcal spaces. This is the part of pons. Okay, this is the interpeduncular cistern, suprasellar cistern. This is the Sylvian fissure. Okay, if I just show you the Sylvian fissure, okay, this is the normal appearance of the Sylvian fissure, because within the Sylvian fissure CSF is present. CSF is present within the Sylvian fissure. It is appearing dark, right? But if you look at this image, okay, this is an abnormal image, because you can see that the Sylvian fissure, it is appearing bright. Sylvian fissure is appearing bright. And guys, what is the reason for this Sylvian fissure to appear bright? It is because of the blood products, or because of the hemorrhage, that this Sylvian fissure, it is appearing bright. And guys, where this blood is coming from? Okay, this blood is coming due to the rupture of the vessels. This blood is coming due to the rupture of the vessels of the brain, and more specifically, it is due to the rupture of the aneurysms. So all the vessels, these are running in the subarachnoid spaces, and when these aneurysms rupture, they fill the subarachnoid spaces with blood, and this blood appear as hyperdensity on the CT images. So here in this image, we can see that there is hyperdensity that is tracking along the sulcal spaces, along the Sylvian fissure, and along the basal cisterns. So this is a typical case of subarachnoid hemorrhage. Subarachnoid hemorrhage, right? So another case, so the important history that will be present in this case will be history of headache. So the patient will complain of headaches. Okay, you will go for CECT head, right? And the first image, this is a normal CECT head, and this one will have some findings. So let me show you what is this structure. So there is some enhancing structure that is present in the posterior aspect in the midline. So this structure is the superior sagittal sinus. Because blood is traveling in the superior sagittal sinus, this superior sagittal sinus will appear bright. Okay, it is going to appear bright, and it is going to take the shape of delta. It is going to take a triangular shape or delta shape, right? But when there is a thrombus within this sinus, okay, you will have a look at this image. So this was the normal appearance of superior sagittal sinus, and on this image what we can see, that within this superior sagittal sinus there is a hypodense thrombus. There is a hypodense thrombus. The thrombus will not enhance. The thrombus will not enhance on the CECT images. And on this CECT images, we can see that this thrombus, it is appearing hypodense, and it is surrounded by a peripheral contrast filled space that is within the superior sagittal sinus itself. Okay, and this is a case of superior sagittal sinus thrombosis, and there is an important named sign that is associated with this, and this is known as MT delta sign, right? Because of the thrombus within the superior sagittal sinus, right? Now I have two interesting questions for you. Let us have a look at these two questions before we end this lecture. So guys, young patient presented to the emergency with a right-sided hemiparesis and vision loss. Diffusion weighted images show infarct in the, so this is the territory of infarct, right? That is involving the left frontal and parietal lobe, and it is also involving the, if you can see, it is also involving the occipital lobe. So let me tell you one more thing, right? So if this is the brain tissue, right? And if there is an infarct involving the parafalcine location. So this parafalcine location, this is supplied by anterior cerebral artery. Right? So this anterior cerebral artery, this is a branch of ICA, right? But if there is an infarct involving this area, okay, this will be due to involvement of the MCA, which is again a branch of the internal carotid artery, right? But guys, if there is an infarct that is involving the occipital lobes, right? So occipital lobes, these are supplied by posterior cerebral artery, and posterior cerebral artery, guys, these are terminal branches of basilar artery. Right? So whenever the thrombus is present, if a thrombus is present, it can either occlude the ICA or it can either occlude the basilar artery. Okay, it can either occlude the ICA, internal carotid artery, or it can either occlude the basilar artery. But it is highly unlikely that a thrombus, acute thrombus is present within both the internal carotid artery or basilar artery, right? So basically what I'm saying, that it is unlikely to have a posterior circulation stroke as well and the anterior circulation stroke as well as at the same time, and this is what is happening in the patient. So there is a stroke that is involving the anterior circulation and it is also involving the posterior circulation. Now what has been asked to us, what is the possible explanation for this stroke, right? Now let me explain it to you. So guys, this is the internal carotid artery. It divides into ACA and it divides into MCA, right? And posteriorly we have basilar artery. It divides into two PCAs. Okay, so both these circulations, these are connected to each other by posterior communicating artery, PCOM, right? But this PCOM is too small for any thrombus to pass through it, right? Now what happens in our case, this P1 segment, okay, the segment of the artery just before the PCOM, this is absent. This P1 segment of the PCA was absent, and the posterior cerebral artery, it was supplied by the communicating artery. So in our case, this PCOM, it was prominent or it was dilated, and when this PCOM is dilated to supply the P2 segment of the posterior cerebral artery, this is known as fetal PCA. Fetal posterior cerebral artery. And when the caliber of this posterior communicating artery is more, okay, it is large enough that it can even cause thrombosis of the, it can even result in thrombosis of the posterior part, that is the occipital lobe. So if there is any thrombus within the internal carotid artery, what it can do, it can result in decreased blood supply to the MCA as well as decreased blood supply to the P2 segment of PCA, and in this case what will happen, that this patient can have a stroke that is involving the anterior circulation as well as posterior circulation, right? So the answer of this question will become, it is not due to the occlusion of the internal carotid artery, it is not due to occlusion of both anterior and posterior circulation. This can be a very rare condition, right? It is due to the presence of fetal posterior cerebral artery, fetal posterior cerebral artery. So the last question. So again guys, there is, if you look at this image, if you look at this image, you can see that there is a hypodensity in both the thalamus as well as there is a hypodensity in both the thalamus as well as a right occipital lobe. So guys, if you have some idea about the circle of Willis, you will see that one side of the brain is always supplied by the arteries on that side. Okay, so if I talk about right cerebral cortex, it will be supplied by the right ICA, it will be supplied by the right PCA, right? The left has nothing to do with it. Now here in this question, there is a patient that is having an infarct on both the sides. Okay, and most likely it is due to the involvement of only one vessel. So guys, there is one vessel, that supplies. So this is a variant. This is not present in every patient. So there is one vessel that supplies both the thalamus as well as the occipital lobe. So what is this vessel? This vessel is your artery of Percheron, right? So if there is an infarct, there is a thrombus that is present within the artery of Percheron, we will see that there will be areas of diffusion restriction in the occipital lobe as well as within the thalamus, right? So guys, this was all about the imaging features of stroke. I hope this short lecture on the imaging features of stroke is helpful to you, and guys, do subscribe our channel and do leave your comments to know your feedback about this lecture. Thank you guys and have a great day.